Well, thank you, Matthias, and thank you for having me here. It's kind of honor to be here and speak here. What I would like to do is discuss how we can individualize tumor treatments today, and what strategies we are using, we have been used, or what should we use in the future. So let me start really very general. I'm an oncologist. I see patients every day. And it's striking to see that oncologists are used to make severe treatment decisions every day based on actually very limited information. In a routine setting, the oncologist is asking for the histology of the tumor, meaning a morphological description of an image under the microscope, basically. And we ask for information from imaging, MRI or CT scanning, to see is there distant disease, basically yes or no. And in most situations, this is the information that we are using to draw our treatment decisions and conclusions. Just an example, a patient that was resected on a primary tumor of the colon, and the pathologist is telling you, well, this looks like a moderately differentiated adenocarcinoma under the microscope. I found 2 positive lymph nodes. The radiologist is telling you, I don't see metastatic lesions in the CAT scan. The decision is clear. This patient needs adjuvant chemotherapy, FOLFOX standard of care, for 6 months. We know from large clinical trials that around 15 or 17% of the patients we treat like this do actually benefit from chemotherapy. That means the vast majority of patients have no benefit from treatments. But we don't know how the patients are that are benefiting from this treatment, so we treat all patients. So this is comparable to a situation where you drive a car and your car breaks down, like the engine exploded, and you call the garage and tell the guy, look, my car broke down, engine has exploded, I need a new one, order me a new one. And the guy is asking you, well, what car are you driving? And you tell him, well, I drive a red car. And it could be this car, hopefully it's this car, or it could be that car, actually this one. So we could do much better in describing the individual disease. And I would like to discuss with you strategies how we might do that. So again, most of our treatment decisions are based on very limited information. What about these standard recommendations? They are based on the statistical outcome of large randomized trials. Those trials define our standard of care. We do not use deep information from single patients for our treatment recommendations. And in those large trials, the individual patient situation is not reflected at all, only the statistics. We know from those trials that adjuvant treatments help the minority of patients. We see, like in breast cancer, in GI cancers, that randomized trials are positive when we see a significant survival benefit, but that could be that 4% of the patients has a benefit. So we treat all patients because 4% do benefit. In metastatic disease, we call treatments effective treatments if we see response rates of 50%. That's an effective treatment, meaning 50% of the patients will not benefit. So how do we go from here? Of course, some strategies are focusing on better understanding the tumor part of the disease, like really characterizing the biology, genetics, expression profiling, like the molecular makeup of the tumor cell as deep as possible, and trying to identify therapeutic targets in there. That's a way that is definitely a way we should follow. One of the recent publications in a last line treatment setting in metastatic disease patients, a French study, a well-done study in my mind, I would like to summarize. In this trial, more than 1,100 patients in situations beyond standard treatment were included. In more than 900 patients, it was possible to successfully biopsy the tumor. They could obtain a molecular signature in 843 of those patients. In about half of the patients, a druggable lesion was identified, an actionable target. Half of the patients then received the treatment, and most of them were available for response. And what they did is they compared the progression-free survival under the experimental treatment with the PFS under the previous treatment. And if the PFS under the experimental treatment was more than 1.3 times the PFS1, they considered this treatment being effective. So how good is that? Well, we do see responses, clearly. We see objective responses here following this strategy. So it's a way that is reasonable for some patients. But we have to invest a lot of actually money and even patients in there. Like in summary, more than 1,000 patients were included. Most of them, it was possible to obtain a biopsy. Again, in 843 of those sequenced patients, a druggable target was identified. Half of the patients received the treatment. The treatment was considered to be effective, objective responses in 22 of those 194 patients. That means 11%. And if we ask for the significance of this approach, it does help some patients, but if you look at the overall number of patients you initially studied or included in this trial, only 7% of those patients actually benefited from this strategy. What I would like to discuss with you today is what my group is actually focusing on. And it's not so much understanding the tumor cell part of the disease. We focus more on understanding the host response to the disease, like the tumor reaction to the progressing disease. And there are data out there for many years. This is a paper from George Kuko's group. He simply studied effector T cell density in primary tumors, in primary ovarian cancers. And he could convincingly show that patients that have a high tumor cell density in the primary tumor have a significant better overall survival than patients with a low T cell density in the primary tumor. Very simple experiment. We know from Jérôme Galland in primary colorectal cancer that again the density of infiltrating T cells in the primary tumor is a strong prognostic factor. He could also show highly significant that patients with T cell high tumors have a significant better overall survival than patients with low T cell density in the tumor. Well, again, what are we using in the clinical routine? We use this purely stage-defined prognostic scale system. And even in the new standards, they tell us we have to treat stage 3 patients, lymph node positive patients, this is this blue curve, with adjuvant chemotherapy. But how does the prognosis look like if we include the information, are there T cells in the tumor, yes or no? The picture looks very different. We have a prognostically favorable group, pretty much independent of the tumor stage 1, 2, or 3. They do well. This is the T cell high group. And we have a group, again, independent of the tumor stage, that is T cell low, that is not doing well at all. And there are even very early stages here, stage 1, 2 patients in this prognostically unfavorable group. Again, what are we doing? What are our guidelines telling us to do? We treat this blue curve and this blue curve, the stage 3 patients with adjuvant chemotherapy, and that can't be right. So we started looking at the significance of infiltrating T cells in the context of systemic treatments, initially in the context of chemotherapy. To do that, we had to go in the metastatic disease situation. We focused on colorectal cancer, actually microsatellite stable colorectal cancer. And we identified patients that had presumably resectable disease, underwent surgery, Intraoperatively, it turned out that not the entire disease was resectable, and patients received systemic treatment after the procedure. So we had material from those patients, and we could judge how effective the treatment is. And what we observed in some patients, this is a CD3 staining, so it stains infiltrating T cells. Some patients had metastatic lesions that were highly infiltrated by T cells, but all those T cells actually accumulated at the invasive margin. They did not really infiltrate in the tumor, and it looked like this in all the patients that were T cell high. We learned right away that it is not possible to draw conclusions from looking at small tissue fragments, like tissue microarrays, for example. If you do that, you have a very high selection bias, depending where you look at. And looking at immune cell infiltrates, it's a very heterogeneous picture. So ideally, you have to look at the entire tissue slide that you focus on. And here comes the pathology into play. So pathology plays a central role, obviously. But how reliable is a pathologist if he is being asked, tell us how dense the T-cell infiltration is in this tumor? And I show you one experiment that was done with a pathologist. Actually, it was done in Switzerland. And this pathologist was asked actually a very simple question. He was shown biopsies, actually kidney biopsies, and he had a Ki-67 staining, so a staining for proliferating cells. And the pathology was asked to judge, is this biopsy a benign or a malignant lesion? So a very simple question. What the pathologist did not know was that he was shown the same image twice, but the second time in a flipped and rotated orientation. And by doing that, you could actually measure the intra-pathologist confusion matrix or classification uncertainty, which was surprisingly high. In this simple experiment, 20% of the analysis were mismatches. So by just asking a very simple question, just involving only one pathologist, we had a classification uncertainty of about 20%, which is remarkably high. And I don't want to ask the question what happens if we involve more than one pathologist or ask more difficult questions than this. So the message is clear, we need automated systems for sure. The human eye is very good in looking at extremes, but the gray shades in between, it's hard to really judge for the human eye. Like I show you in this very simple experiment. If I ask you to look at the squares A and B and tell me which square is lighter, I guess you will tell me square B is lighter than square A. But it's not. It's basically the same. So we need automated systems, for sure. And over the past years, we set up such automated systems in Heidelberg. So what we are using is we use high-resolution scanners that scan the entire tissue slide. And we developed automated algorithms that count cells of interest, whatever cell you're interested in, and you can stain those algorithms count. And they deal with all the difficulties of cell clustering, not uniformly shaped cells, and so forth. So what we are doing is we are systematically analyzing, let's call them immune cell infiltrates. We look for spatial distribution as well. We look for cell-cell vicinity, potential cell-cell interactions in the entire tissue slide. All those different stainings are established, so we look at all different cell subsets from the immune system. And in parallel, we separate from frozen sections, tumor center, from invasive margin, from adjacent normal. And we do proteomic analysis in there, mainly looking for cytokine and chemokine concentrations. And if you do that, you understand right away that tumors are very heterogeneous. And if you look in colorectal in different patients, every patient looks different in terms of immune cell subsets. So a very heterogeneous picture. If you compare different tumor types, they're even more heterogeneous to each other. And if you look in one single patient at different metastatic sites, so if you compare the primary tumor with the liver metastasis with the lung metastasis, and look at the immune contexture of the tumor environment, you see striking differences in the different organs. Well, back to the initial questions we asked. In patients with metastatic colorectal cancer that are either T-cell high or T-cell low, do we see a significance of such infiltrates in terms of response rates or progression-free survival or overall survival? And it was for us surprising to see. We scored the T-cell density. A low score means no or low T-cell density, higher scores high or very high T-cells, that not one single patient with a low T-cell count at the invasive margin had an objective response to chemotherapy. All the patients that had moderate or intense T-cell infiltrates at the invasive margin had an objective response. And if you compare PFS in the T-cell high group of 16 months versus T-cell low group of 5 months, you see a highly significant difference. You see a difference even in overall survival, and this is first-line treatment situation in MSS colorectal cancer. So obviously those T-cell infiltrates are not only prognostically significant, they are also predictive. Again, you see patients like this, high T-cell density at the invasive margin, patients like this, basically without any T-cells. So we were interested to understand what attracts T-cells to the invasive margin in some patients, in others not. So we took a closer look at actually the invasive margin. And if you look for cytokine, chemokine concentrations, gradients over the invasive margin, you identify quite a number of cytokines and chemokines that show log-fold concentration differences at the invasive margin. So we look at immunologically distinct different compartments, invasive margin versus adjacent normal versus tumor center. And in MSS colorectal cancer, if you look at cytokine, chemokine signatures, and Niels Hallermann did that in my group, is that such T-cell high patients that do well under chemotherapy, have a lot of T-cells at the invasive margin, have a more chemotaxis-dominated cytokine signature at the invasive margin. Whereas patients with low T-cells at the invasive margin, they have a more macrophage-dominated or macrophage-related signature at the invasive margin. We had many ideas looking at those cytokines that are responsible for this situation or this situation, how to go from there and identify potential therapeutic targets. And CCR5 was one of those targets. CCR5, I will show you the data, is highly expressed in pretty much all tumors, where the ligand, RANTES or CCL5, is highly expressed at the invasive margin. And to get an idea, what is the effect if we modulate the environment, if we block cytokines, therapeutically interfere there? We decided not to rely on more or less artificial mouse systems. We decided to study that in a human situation. That's why we developed that we call that human tumor explant model. So what we do here is we take a piece of tissue, and this is millimeter in size, that contains tumor, invasive margin and adjacent normal. And we developed a kind of culturing condition in a bioreactor system where we can keep the immunological environment very stable for a few days, depending on the tumor type. Colorectal is very stable for 3 up to 4 days. In ovarian cancer, it works up to 8 or 9 days. So, and if you have this tumor with an intact human immune system in there, you can actually treat that and see what is the immediate treatment effect. This is such an explant model system of a metastatic lesion, MSS colorectal, and we treated this tissue with a CCR5 antagonist. Again, here baseline, you see again this intense T-cell infiltrate, kind of trapped at the invasive margin, not really infiltrating in the tumor. And that happens 2 days under CCR5 blockade. You see a redistribution of T cells and you see induction of necrosis here in the tumor. We were pretty impressed by what we saw there, so we decided to go in a phase 1 trial. And this was a trial in chemotherapy refractory patients with metastatic disease, MSS colorectal. We took from all patients a baseline biopsy from a metastatic liver lesion. All patients received CCR5 antagonist. It's approved for HIV indications as a monotherapy. And we did an early rebiopsy, about a week, 10 days under treatment from the exact same liver lesion. So we could look at the immediate immunological effect of our treatment. So what we saw is that one of the, I guess, driving chemokines that attract T cells to the invasive margin is CXCL9 and CXCL10. They peak at the invasive margin. Those chemokines are expressed by myeloid cells. And we see that CCR5, the receptor, is highly expressed in the metastatic lesion, not really peritumoral. Whereas the CCL5, the ligand, is highly expressed by lymphocytes that actually accumulate at the invasive margin. CCR5 is expressed by CD8 T cells and CD4 T cells at the invasive margin. So what happens if you treat this patient with a CCR5 inhibitor? You see a significant decrease in several chemokines, like CXCL8 is going down significantly at the invasive margin. VEGF is going down at the invasive margin. MIF, one of the highest expressed cytokines in colorectal, is significantly going down. And you see what's immunologically very interesting, alpha interferon is going up significantly at the invasive margin. In the patients we treated, 12 patients in this phase 1 trial, we observed the exact same changes in cytokines that were predicted by the explant model system, like CXCL8 is going down, VEGF is going down, MIF is going down, and alpha interferon is going up. These were end-stage patients, refractory patients. We observed even some remarkable clinical effects. Some patients showed like central necrosis in metastatic lesion, and some patients had an objective response of single metastatic lesions under CCR5 inhibition alone. Those effects were not long-lasting effects. And immunologically, it makes a lot of sense by combining CCR5 inhibition with checkpoint inhibition. That's pretty obvious. And we tested that in the explant model system. I don't show you all the data. We had intriguing effects in this model system, and that's why we decided to go into the human situation. This is a patient with pancreatic cancer, kind of last line setting, that had this bulk tumor lesion here that we treated with this combination CCR5 inhibition plus combination checkpoint inhibition. This patient had a nice partial response lasting for many months. We had a second patient, a metastatic disease colorectal cancer patient, refractory to all known treatments. Again, received the combination, just the PD-1 inhibitor plus CCR5 inhibitor in this case. If you look at this bulk tumor lesion here and this lymph node metastasis, it also went into a nice partial response that is still actually ongoing. We had some other patients that had objective responses. If you look at the literature, checkpoint inhibition in pancreatic and MSS colorectal cancer, objective response rates around 5 or 10%. So you don't really see responses there. So we were intrigued by those findings, and that's why we decided to go now in several prospective clinical trials. This trial actually will start in the next few weeks. It's a last line setting in metastatic disease colorectal, MSS, with a combination of PD-1 inhibition plus CCR5 inhibition. In January, we'll start this phase 2 trial in second-line situation, MSS colorectal and pancreatic cancer, using the combination of checkpoint inhibitors, Ipi/Nivo plus CCR5, and in collaboration with Bristol Myers Squibb, we started an international multi-center trial systematically testing CCR5 and CCR2 inhibition in combination with chemotherapy and in combination with checkpoint blockade in metastatic disease colorectal cancer. So we are intrigued by what we are seeing using immunotherapy, mainly checkpoint inhibitors. In the melanoma field, we observe metastatic disease patients now for many years, 10 years, we're actually 10-year survival data. And it's striking to see that in a, per definition, non-curable disease situation, about 20% of the patients have obviously a long-term response by just using the first approved checkpoint inhibitor, a CTLA-4 antibody. We see higher efficacy using combinations, PD-1 plus CTLA-4 inhibitors, here again in melanoma. Now 3 years survival data, we see now almost 60% of the patients still being alive 3 years under treatment. These are data we couldn't dream of years ago. And if we see now long-term, these are the EP data, 20% long-term survival, Nivo maybe 30% long-term survival. And if you look at the combination, we might see or look at maybe 40-50% of patients that show long-term survival by using a checkpoint inhibitor combination. Of course, this is melanoma, but it works also in other tumors. You know the data. This was the phase 3 trials that led to approval in second-line situation, non-small cell lung cancer. You see a significant overall survival benefit by checkpoint blockade, PD-1 antibody versus standard second-line chemotherapy. In squamous cell carcinoma, what's striking is not the response rates, it's the durability of the responses here compared to chemotherapy. It works also in adenocarcinoma. This is the approval trial, second-line situation. Again, a significant difference in terms of overall survival for the PD-1 antibody. We see now many more approvals in different tumor situations. Obviously, it makes a lot of sense to combine checkpoint blockade with radiotherapy. This was actually shown at the last ESMO meeting in non-resectable stage 3 non-small cell lung cancer. Standard of care, radiochemotherapy versus radiochemotherapy plus 1 year PD-L1 antibody. And you see a highly significant benefit of the PD-L1 antibody. What we still don't understand so far is why do we see remarkable responses in some patients using checkpoint blockade? Some patients develop only a partial response. Some patients are primarily progressive under disease. We don't understand that. And a little oversimplified, it's obviously that you need a kind of pre-existing immunity. You need anti-tumor T-cell responses to have checkpoint inhibitors to work in a patient. But you also need a friendly environment, a tumor microenvironment that lets the immune system in. And I showed you all these colorectal data where you see this accumulation of T-cells at the invasive margin. Obviously, it's an unfriendly environment, and you have to do something about that to make checkpoint inhibition work in this scenario. Immunotherapy, mainly checkpoint blockade, is difficult in a situation where there is no or insufficient pre-existing immunity or an unfriendly environment. But even if you have a friendly environment and no pre-existing immunity, those treatments will not work. So immunotherapy is a very complex treatment modality, and there are multiple steps that have to work to make immunotherapy really active. So you need targets in the tumor that are detectable, visible, recognizable by the immune system. You have to prime T cells that recognize those targets. Those T cells have to be activated. They have to travel to the tumor site. They have to leave the blood vessel system, and they have to infiltrate in the tumor. And then they have to recognize the specific target antigen, and they need the required co-stimulatory signals that they eventually can actually kill the tumor cells. So it's a multi-step process, and of course this implies that there are many potential escape mechanisms that tumors can use to evade immunity. To better understand what are really the preconditions for immunotherapy, but also other systemic treatments to work, or identify patient populations that are not likely to benefit from systemic treatments, we just started a huge non-interventional trial in first-line metastatic disease setting non-small cell lung cancer. So what we do here is we take open biopsies from metastatic lesions in lung cancer patients. We will include 150 patients in this cohort, and we deeply characterize. We do NGS, we do expression profiling, we do the entire immunological workup, we quantify infiltrating immune cells, we look for cytokine chemokine testing, and we do, if possible, also explants in there. The idea is to identify biomarker signatures that are predictive for systemic treatments. And just looking at T cell density at the invasive margin and colorectal, we are already predictive in terms of, in 86% of the patients, we can accurately predict, is this a patient that is likely to respond to chemotherapy, yes or no. So the idea is here to really identify biomarker signatures that predict response, or even more important, resistance to treatment. And if we are successful in identifying such signatures, then we will go in a randomized setting and compare biomarker-triggered treatment decisions versus standard of care in first-line metastatic disease setting. This is a huge program, 150 patients, 50 million euros to do the entire analysis. In parallel to that, I'm a physician, I'm a medical oncologist. It's almost impossible to handle this deep information that we are getting from individual patients, like taking a look at an exome sequencing file, or looking at those complex immunological information, spatial distribution, different immune cell subsets, potential cell-cell interactions, vicinity of different cell subsets. It's impossible for me to make sense out of this data. So what we desperately need, and we're also working on that, is a modeling system that is filtering out the relevant information of this deep molecular and immunological profiling. And the first experiments that we are doing are, I'm not a computer guy at all, but are very impressive. They kind of simulate the situation. This is now T cell accumulation at the invasive margin, and this modeling system was just taking the cytokine signatures from individual patients. So this system kind of predicts how will this immune system react to a certain signature, and we are now working on model systems that predict how will a complex immunological system react to a specific treatment, and we will see how far we get there. Well, I would like to actually end with my idea of the term precision oncology. I'm strongly convinced that we have to change oncology significantly. It's not possible to just use the morphological description of a microscopic image as the information to guide treatments. We have to look at deep molecular information, and hopefully I could show you that we also have to look at the immunological information that is in the individual tumor sample. We have to make sense out of this information. And I guess we have to work on modeling systems that help us then to design the hopefully optimal treatment for an individual patient that could consist of the conventional treatments, targeted drugs, immunomodulatory strategies, vaccines. I haven't mentioned that. We are starting now with a mudanome-based vaccine strategy. That means we have to design a treatment that is only good for one patient. It works only for this patient. So we have to do a GMP manufacturing of a vaccine for a patient based on the exome sequencing data of this patient. That could consist of cell-based treatments, of adaptively transferred T cells that are genetically modified or even unmodified. In most situations, I guess it will be intelligent combinations of the different treatment modalities. We have to get used to, and we do that more and more, that we take sequential biopsies from patients. We have to understand what is the treatment really doing immediately on the tumor. In a routine setting, we treat the patients and look 2 or 3 months later under treatment what happened. Is the tumor growing or is it not growing? To better understand the mechanisms of response and, more important, resistance, we have to take early second biopsies to see what is the immediate effect of our treatment on the tumor. All those information is very important information that is feeding then the modeling systems and are improving those modeling systems. With this kind of outlook, I would like to close. That's where actually I practice. This is the Heidelberg campus, the University Hospital campus. This is the so-called NCT. We have huge outpatient facilities in here, lab facility, part of it. And part of the campus is the German Cancer Research Center, which is also located here. And there is a very fruitful interaction between hospital and German Cancer Research Center. Thanks a lot for your attention and happy to answer any questions if you have questions.